Hello, my name is John Phillips. I'm here at Westchester Medical Center and giving a talk on complications of urinary diversion. You can email me at jlphillipsmd@gmail.com. It's a pleasure to give you this talk, and you can always either use that email address or editor@iguh.org. Here's a view of Prague, 1910, the time of great innovation in surgery. This town of turn of the century starched collars and hoop skirts is also the city of some of the pioneers of urological surgery. It was the location of the first successful cystectomy in which the patient recovered. We'll go into that in a little bit, but the surgeon was Karl Pollock, who followed in the footsteps of Bardenhauer to determine how to best get the patient through surgery with a urinary diversion. But before we get into a little bit of that history, we need to speak about the hard facts of bladder cancer. First of all, this is not particularly common cancer. Its incidence is about 21 cases out of 100,000 people. Compare that to prostate cancer. The incidence, depending on the age, of course, will be between 300 to 700 per 100,000 men. So this does rank fifth in all solid organ malignancies in some groups. What is different though is the mortality of bladder cancer. You can see here that the death rate is about 4 out of 100,000, whereas in the prostate cancer, it's between 1 in 10 to 1 in 25, depending on the risk group. So this is a less frequent but more lethal cancer. The male to female ratio usually favors males. It was thought to be due to smoking, but may in fact have to do with the androgen receptor. And the survival of advanced bladder cancer or even muscle invasive bladder cancer is rather dismal, with only a 50% 5-year survival rate. New York ranks 15th amongst states for the prevalence of bladder cancer in men, that is. But some counties in New York have a very high rate of bladder cancer. Montgomery County, which is just southwest of Albany, is actually ranked 9th in the United States. And that's compared to all the counties in the South, the Tobacco Belt. So there are certainly some areas of New York that have high rates of bladder cancer. The green areas, such as New York City, a lot of people are walking, a lot of people are relatively healthy compared to other parts of the state, and they have lower levels of bladder cancer. Indications for radical cystectomy, of course, the most famous, of course, would be the muscle invasive bladder cancer. But also, a cystectomy is indicated for people who have non-muscle invasive bladder cancer, but may have recurrent or refractory non-muscle invasive bladder cancer. As you know, AUA guidelines suggest that one of the options for T1, high-grade multifocal T1, is a radical cystectomy, but it's also indicated for failure of intravesical therapy, as well as the bladder cripple. These are patients who may be rendered cancer-free but have no bladder function or small capacity bladder. So we speak of the morbidity of bladder cancer as being, number one, the bladder cancer itself on the patient, but also the treatment of the cancer itself has some morbidity. And this should not be discounted, from neoadjuvant chemotherapy to surgery to all of the complications. So there's perioperative morbidity, DVT, PE, wound dehiscence, bowel complications, of course, the morbidity of chemotherapy. And we think about anemia and neutropenia, but we also have to think about hearing loss and other elements of the senses that we sometimes don't think about in urology. There's also the morbidity of the urinary diversion. This is the paper by Harry Herr, one of the revered professors of urologic oncology at Memorial who submitted this paper to the International Journal of Urologic Oncology. This is Bernard Bardenhauer, who did the first cystectomy in Germany, in Heidelberg. That patient did not survive the recovery. And so the honor goes to Pollock, who had a patient, a female patient, who survived the surgery and had for some time a kind of a pouch, as it were, a reservoir for the urine. So you can read about those two urologists in Dr. Herr's article at www.ijuh.org. And in fact, if you peruse the journal, you could find opportunities for you yourself to submit a history of urology journal. And there is a drop-down menu at that website for instructions to authors. But let's continue a little bit about the evolution of the art of cystectomy. This is George Smith, one of the revered urologists of New York, who spent most of his career in Boston, Massachusetts, and was honored at the AUA history exhibit at the past AUA meeting, this in 2023. He wrote here, in no field of genital urinary surgery are the results more disheartening than those which follow operations for carcinoma of the bladder. And he agreed that the crux of the whole question is the diversion of the urine. So let's talk a little bit about the first methods of urinary diversion. First of all, nephrostomy was described, largely in patients who had exstrophy of the bladder or a complete obstruction of the ureters from tuberculosis. Obviously, this is a more of an ancient problem, but placing tubes into the kidneys was felt to be a way to alleviate all the problems from downstream urinary difficulties. Ureterostomy, of course, is a good way to divert the urine in children, not so much in adults. And famously, they, around 1910, 1915, started to plug the ureters into the sigmoid colon for ureterosigmoidostomies. First popularized by Krause at the turn of the century. So image of a nephrostomy tube. In those days, we'll just move this little image out of the way. And rudimentary equipment, of course, is always important to consider that our modern equipment allows these things to occur. Ureterostomy, diverting the ureters directly to the abdominal wall, is not easy to do on adults. The ureters tend to stricture. This is mostly reserved for the dilated ureters in children. This is a side view of a ureterosigmoidostomy. You can see the ureters coming in here through the muscular linea of the colon, and then the ureters themselves being retroperitonealized. And this was this was the standard of care for many, many decades in urology. And there were battles as to how the ureters should best be implanted. Downsides, of course, of ureterosigmoidostomy would be notorious, including fecal urinary incontinence, ureteral obstruction. They still hadn't worked out good ways to implant the ureters into a muscular structure like the colon. Electrolyte shock, not easy to measure back then and harder to treat. Urinary stones were not uncommon and with no real good way of treating them. Ascending infection through the ureters and septic death. And of course, colon cancer at the site of the anastomosis because of the admixture of urine and stool, usually mediated by nitrosamines, is a hazard ratio of 100. That is, somebody who has urine and stool mixing at the same time has a risk of colon cancer 100 times of those who have had complete urinary diversion. So any patient you meet who has had a history of ureterosigmoidostomy has to have had at least a colonoscopy and should maintain a colonoscopy every 2.5 to 5 years. Rise of modern surgery got rid of a lot of these problems. And it wasn't just that we were more careful with our preoperative evaluation, treating hypertension, treating diabetes, treating the risk of infection, but also being able to monitor renal function and electrolytes. Anesthesiology has become amazingly safe. We've also been able to prepare our bowel segments for urinary diversion in the days in which that wasn't possible or feasible. And we also have to appreciate those who develop the ostomy appliances. We almost blow off how easy it is to put on a good ostomy appliance, but these were not easy, even up until the 1960s. They always fell off and had to do with suturing pieces of rubber onto the abdominal wall in hopes that the urine would just drain into this collection bag. The ureter started to become spatulated in the 1960s because it was realized that placing a non-spatulated ureter onto a section of bowel, it would stricture for sure. And so the concept of detubularization had a reflection of the anatomy and reconstruction methods, understanding the pathophysiology, complications of bowel use, which segments of bowel to use, and how to reconstitute or reanastomose the bowel together with different technologies, including staples. And of course, the concept of detubularization was not only applicable to the ureter, but also to the bowel itself. So, options for urinary diversion. You must know for your in-service examination that different parts of the bowel can be used for different types of urinary diversion, but it's almost just a historical note that we still talk about stomach. It's almost never used for isolated urinary diversion in adults and was only used in children for an augmentation cystoplasty, usually in the setting of overwhelming acidosis. So it was thought that the stomach could deliver or get rid of excess acid. Of course, there are huge downsides, including the effect of acid on the bladder, which can only be partly mitigated by the use of omeprazole. Large bowel, obviously, is a more comfortable section of bowel to use. It has a rich vascular supply. It's very capacious, a lot of mucus production, and that can be problematic. But you should know the anatomy of the bowel, especially its vascular anatomy, has to do with the supply of the proximal parts of the hindgut from the SMA, and then this gives rise to the middle colic artery, and then we have the descending loop of the bowel. This is usually perfused by the IMA, and then of course the hemorrhoidal arteries. But you should also know that it's safe in many adults to divide the IMA. The bowel can receive blood supply through the marginal artery of Drummond and through a deeper arterial plexus, not so much the marginal artery because it's more towards the mesenteric root, but the arteries of Ryelin. I've never seen the arteries of Ryelin, but we know they're there because the IMA can be divided and the colon can happily perfuse along. However, there are two areas that you should know about. One is Griffith's critical point, and the other is Sudik's critical point, that if you do have to do an anastomosis, these areas are watershed areas for blood supply and may not heal as well. Caveats to the use of bowel, of course, would be inflammatory bowel disease, Lynch syndrome, and polyposis. But it is an ideal section to use, especially for irradiated bowel, is the transverse colon. It's almost never irradiated. Most of us, of course, are using small bowel, and there are important differences between jejunum and ileum that you should know about, not only for your in-service examination, but also for intraoperative management. Both of these sections are perfused by the SMA. The arterial arcades are somewhat different, but the ileum has a double row and a longer section here, the marginal arteries than the ileum. The vasa recta of the ileum tends to be shorter. You can see here in the jejunum how much longer the vasa recta are. The jejunum encompasses about 2/5 of the 22 feet of small bowel, so there's more ileum around. But remember that the length of ileum of about 15 centimeters can live off one vessel. So it's very important that when you isolate a section of bowel, that the edges of the bowel or the margins are equidistant from the vessel or vessels perfusing it. And it's unwise to isolate more than 8 centimeters off of the ileum that's that far away from a perfusing vessel, because you could risk necrosis of the distal or proximal end. It's always nice to palpate the pulsation of a mesenteric vessel as you bring your ileal conduit into the abdominal wall. It may be very hard to do robotically, but using 2 cc's of ICG intravenously, should be able to fluoresce the mesentery of the bowel quite nicely. We avoid jejunum not so much because of its length, but because of electrolyte abnormalities, which we'll talk about soon. We always use a coker as a ruler of sorts to measure how much bowel we need for an ileal conduit. This generally is about 15 centimeters. Eugene Bricker was an amazingly innovative and pioneering surgeon who saw a lot of people, especially children, who had had devastating congenital problems and needed to have both urinary and fecal diversion. But he also saw a number of adults who had exenterations and needed to have fecal and urinary diversions. And so he recognized quite early on that almost all ureterostomies fail in adults. And so he addressed the problem of ureteral implantation after an exenteration by finding various pieces of bowel and reimplanting into them. So you can do the math here that he was born in 1909 and began his first attempts at not only urinary diversion, but urinary diversion with a continent reservoir, in his late 30s. So really quite a pioneer. And so these are some of the options he saw. So all four of these patients had colostomies and colostomies. And you can see here that he used a section of stapled off sigmoid colon to divert the urine into a separate urostomy. He also used a pouch of cecum here and the distal ileum and plugged in the ureters here in hopes of having a continent reservoir per se. And you can see here in C how we tried to then use the ileocecal valve of this pouch to provide a cecal reservoir, and that this stoma could be intubated with a catheter to relieve the reservoir. And then lastly, an isolated piece of ileum, which we all know now as a Bricker conduit, but you can see here that Bricker was doing a lot of other conduits at the time. Importantly, it's the concept of isolating the section of ileum for conduit is important to drop it posterior to your anastomosis because we want to have this pseudo-retroperitonealized. If anybody ever comes into the abdominal cavity ever again, we don't want them to injure our ureters or our bowels, so it's best to drop it posteriorly to the anastomosis. We also know that the anastomoses that Bricker described, and which we do now, are a classic side-to-side anastomoses, spatulated ureters here, and anastomosing it in that fashion. The proximal end of the conduit is stapled off generally, so this has to be closed with Lambert-style sutures, and then the stoma matured. For a robotic conduit, we normally do Wallace anastomoses, and we'll show you an image of that pretty soon. The nice thing about this bowel is that it is isoperistaltic. It is rushing urine out through the stoma, so it's important to make sure that you orient the conduit correctly. Remember to spatulate the distal ends of the ureters and to avoid any kind of instrumental manipulation of the ureters, because the more that one does, the more damage that can occur. We almost always stent these anastomoses. There are some groups that show that stented anastomoses have stricture rates that are no better than stented anastomoses, although it may provide more comfort for you. Remember to use resorbable suture. Because non-resorbable suture will act as the nidus for stone formation. Now remember that these are refluxing anastomoses, and that we have to consider the fact that almost all patients will have some bacteria refluxing into the kidneys. So it's very important that we monitor them with not only serial creatinines, but also renal ultrasounds to make sure that there's no upper tract deterioration. A rosebud stoma is very important at the abdominal wall, because remember, the appliance has to sit almost below the level or below the verge of the stoma itself, so that the urine flows effortlessly into the collecting reservoir. For flat or sunken stomas, these most almost never have a good seal with the appliance, and these typically leak. The appliance will come off, and is really a situation to be best avoided by first having the patient sit up in the holding area before surgery and marking a flat area of their abdominal wall where you're going to be putting the stoma later in the day. It's also important to redo the entire anastomosis or the urostomy itself if it looks like you cannot get the rosebud to form. Worst case scenario is you can bring a loop of the distal bowel up in through the abdominal wall, especially in obese patients, and then evert the edges of that loop urostomy into a rosebud. The downsides of these types of anastomoses, of course, the cosmesis of the urostomy, especially the younger patient, the reflux that we already described, and renal deterioration, which almost always can ensue with reflux urine containing bacteria. Ureteral strictures are a problem in almost 30% of patients. Some of these can be managed endoscopically, but if due to lack of vasculature or malignancy, almost always have to be remediated with an open or robotic repair. The ischemic loop and stenosis is a dreaded complication and generally can be avoided by ensuring that your bowel has good vasculature before you finish the case. And again, redoing the entire loop if it looks like you need to throw that section of bowel away. Peristomal hernia may occur in almost all patients, especially since you're creating a hernia through the abdominal wall. One way to avoid this is to bring the stoma itself through the rectus abdominis muscle. That way, at least the muscle is contracting and hopefully buttressing the effects of the peristomal hernia. Fixing these is not easy. They almost always have to be reduced from the peristomal hernia. That hernia closed with mesh, and then the stoma, the urostomy, brought to the contralateral side. That's called a urostomy transposition, and can always be done in patients who have had a urostomy a long time because their bowel will be somewhat pliable and can often reach the contralateral rectus abdominis without redoing the whole thing. Other complications with taking too much ileum is, of course, that you're not able to absorb the bile salts and fat-dependent vitamins, including vitamin B12, which, as you know, can lead to megaloblastic anemia. But other important vitamins, including vitamin A for vision and vitamin K, of course, for clotting, can also suffer. So we check a B12 level in almost all of our patients on an annual basis because it takes a long time for that to occur. Continent diversions are a very important mainstay of urologic oncology, and you should at least know about the choices of them and their complications. If you don't do them yourself, but you may be on call and handling those patients who do have continent diversions. These are less popular because they're more work and less time reimbursed, but the ratio of ileal conduits to continent diversions is usually 10-1, so continent diversions are clearly less popular. There are several problems and challenges. First of all, without detubularizing the bowel, there's a problem with wall tension and contractility. And this was a real problem early in the evolution of this science by creating a reservoir that easily reflux urine back up into the kidneys. So it's one thing to have bacteria, but it's another thing to have high pressure bacteria because that will always lead to rapid renal deterioration. Resorption of electrolytes is the rule unless the reservoir is adequately drained. Reflux in a high pressure reservoir is a high risk for renal failure, and therefore detubularization of bowel must be done in a complete manner prior to reconstituting the bowel into a reservoir. The biggest risk here is, of course, poor drainage of the reservoir, and that is if the patient's unable to catheterize the reservoir or unable to empty the reservoir, they will have all of these stigmata of problems related to these continent diversions, including electrolyte abnormalities and infection. Renal failure almost always ensues, and patients can develop overwhelming acidotic shock. Now, remember, in Laplace's law, the pressure of these continent diversions is generally related to the radius. And so the larger the radius, the less the pressure on the urine and the less likely to reflux. So the more you can detubularize safely, the less pressure in the continent diversion, the kidneys will be better protected. Now, continent diversions come in two types. There's the orthotopic, of course, going to the urethra itself, and the cutaneous, which is the one that Bricker tried to develop, but has become more of a state of the art with the Indiana or Miami pouches. They have great storage, can be up to 500 cc's, but don't start out that way. So a typical pouch starts out with a 250 cc volume and can over time expand greatly, and even can exceed 500 cc's. These are often at low pressure, and the majority of patients have good daytime continence because of good external sphincter control, but they have to be told that nighttime incontinence may be assumed because the external sphincter will relax and there's no intrinsic sphincteric ability for the neobladder to maintain continence, and the urine may just leak out. So a lot of these folks may be wet at night unless they can try to drain the bladder before going to bed. Absolute contraindications for a continent diversion, of course, would be cancer at the distal urethra if you're trying to do an orthotopic diversion. If the patient already has incontinence and that won't be addressed, it wouldn't make sense to remove their bladder and replace it with another bladder that's just going to be incontinent again. Of course, patients who have advanced bladder cancer may not live long enough to appreciate the benefits of a continent diversion. And patients who have poor renal function may not be able to endure the consequences of renal deterioration from reflux. It's very important to ensure that your patients can catheterize themselves before embarking upon a continent diversion. Some patients may be unwilling or unable to catheterize because of poor hand-eye coordination or neurological problems, or just refuse. And it would be a difficult situation to have an orthotopic or cutaneous diversion and no one around to be able to catheterize it. Some choices for a neobladder or continent diversion would be a Studer neobladder. This is what we typically use robotically. And the Studer, as you know, has a low pressure reservoir, but with a non-detubularized section of proximal ileum. This allows the two ureters to be plugged in at the most proximal part of that proximal bowel so that the isoperistaltic function will forwardly propagate the urine into the reservoir where it sits and expands and then can be emptied later. This is not a good choice if a patient has ureteral stones, or you need to access the ureters, or there's a history of needing ureteroscopy. So that brings up patient variables that you have to evaluate your patient to determine who is a good candidate for what type of diversion. You also have to be comfortable doing these procedures. And I'd say the learning curve is about, you have to do probably 25 to 50 to really feel comfortable handling all sorts of patient variabilities. Again, if you need to access the ureters, then this may not be a good option for you because you have to navigate all the way through that afferent limb, or access the ureters from above with percutaneous nephrostomies. Gender is important. Males are almost always easier to handle an orthotopic diversion than a female, largely because the short urethra in the female may sometimes render it difficult to relax to Valsalva urine. And also the absence of part of the vagina allows the neobladder to sort of retroflex and can create a situation of hypercontinence. Body habitus is important. Sometimes the morbidly obese may be better candidates for a neobladder than familial conduit. If you do need to access the ureters in an orthotopic neobladder, then a Hauptmann or W pouch may be more appropriate. In this situation, the ureters are tunneled through the grooves between the folds of the detubularized ileum, and they're really actually close to the bladder neck and can be easily identified and accessed from below. The largest consequence of neobladders and urinary diversion would be the metabolic abnormalities, and that generally results from incomplete emptying in this vicious Krebs cycle. So incomplete emptying almost always leads to high pressure and reflux, and therefore renal failure. But it also may lead to absorption of acid. And if your kidneys are also failing, then that can compound the acidosis. Acidosis can further lead to decreases in mental status, and that may lead to decreased decision making and the ability to empty the neobladder, thus feeding this vicious cycle. So acidosis can be life-threatening and largely depends on the type of bowel used. The surface area of the bowel is important, that the longer the urine dwells in a neobladder, it's exposed to all that surface area. There's more of an opportunity for urine to be absorbed, as opposed to an ileal conduit in which the transit time of urine through the ileal conduit may not expose a great surface area to urine to allow these processes to occur, and therefore has less dwell time, as opposed to a continent diversion, which has a very high dwell time, and sometimes patients may only be catheterizing 2 or 3 times a day. Clearly, renal function can be threatened and therefore further deteriorated, which is why we want to have patients have good renal function prior to doing a continent urinary diversion. A little bit about the bowel section. So we spoke earlier about stomach. Again, very hard to isolate a section of stomach and form it into a complete urinary diversion. But for academic sake, we do talk about the fact that the metabolic abnormalities are usually ones of alkalosis. You're just losing hydrochloric acid. And therefore, it's a hypochloremic metabolic alkalosis. And also found patients have increased carbohydrate or bicarb in their serum and increased levels of gastrin. Again, academic note, you'll probably never see a patient who has a augmentation cystoplasty with stomach. Most notoriously, uses of jejunum and ileum in large bowel will result in acidosis. With jejunum, you normally see a hyperkalemic, hypochloremic metabolic acidosis with increased renin, whereas in use of ileum and bowel, you almost always see a hyperkalemic, hyperchloremic metabolic acidosis. And curiously, as the acidosis increases, calcium is sort of leached out of serum, and you tend to have this hypocalcemia. So signs of acidosis would be stupor, pallor, and almost always dehydration. You can almost see urea on the patient's skin who is severely acidotic and dehydrated. They're tachypnic because they're trying to blow off all that acid. And if you do their blood work, you can definitely see a lot of electrolyte abnormalities that a lot of internists and emergency room doctors may not be familiar with, including profound acidosis and an increased creatinine. And they may get a nephrology consult before they get a urology consult. And a nephrologist may be willing to do dialysis when dialysis is not really needed. An arterial blood gas is needed to check for whether or not the metabolic acidosis has appropriate respiratory compensation, because in severe cases, these patients may need to be intubated to help blow off some of the gas in severe states. An elevated creatinine may not necessarily be the sign of obstruction, but absorption of the creatinine from the urine itself. Acidosis and septic shock is a reality with uncompensated metabolic acidosis and infection, and needs to be relieved immediately with antibiotics. It's important to understand the pathophysiology of the metabolic acidosis. Essentially, what happens in ileum is that there's an absorption of ammonium chloride from the urine through a sodium potassium chloride co-transporter. And to compensate for this, we lose bicarb into the urine. So this is a obligate loss of carbonate, so a carbonaturia, and this leads generally to the hyperchloremic metabolic acidosis. The most important thing you can do as a resident or as an attending and seeing somebody who has profound acidosis or sepsis in the setting of a continent diversion is ensuring that the continent diversion is adequately drained. That will stop that vicious cycle and allow us a chance to compensate with the fluids they desperately need, the antibiotics they desperately need. Place a Foley catheter into the continent diversion, irrigate out all the mucus, relieve the obstruction. If they have an ileal conduit and there's really no place to put a Foley catheter in, they in fact may need a Foley catheter just to ensure that the urine is not being obstructed by the abdominal wall itself. The worst case scenario, of course, they have obstruction at the level of the anastomoses or blown out hydronephrotic kidneys that may need a unilateral or bilateral nephrostomy tube. Hydration is critical. These patients are chronically dehydrated and serum contracted, so they need a lot of plasma and electrolytes. So give them half normal saline without potassium because they may be hyperkalemic. Again, omeprazole for patients who have gastrocystoplasties. I've never seen it, but that's what they ask on the in-service. But for all ileal segments, especially continent diversions, they need volume and fluids, and often they need bicarb. Most of my patients do take oral bicarb, usually 325 twice a day or 3 times a day, until we're certain that their continent diversions are not going to lead to more bicarbonate loss. K-xylate is very useful acutely for the patient who has hyperkalemia, because as you know, the colon is our third kidney and can be used to create a loss of potassium into the feces, and may be a rapid way of getting rid of excess body potassium. If you give somebody insulin and glucose, you can lower potassium, but it's just driving it into the cell. So to get rid of it from the body, you can induce a diarrheal stool. Again, dialysis may be the go-to for an emergency room attending or for a nephrologist who's not familiar with these situations, but is almost a last resort if the continent diversion has been drained and the urine is flowing. We're moving on to the robotic era. Some of these principles of open surgery really must be maintained in the robotic era. And we'll just go through a few of them. So as you know, the most important part of a neobladder is the anastomosis. If you can't catheterize or drain the bladder, you're not going to be able to relieve obstruction and lead to all those consequences of metabolic acidosis. So it's nice with robotic surgery that the anastomosis can be done under direct vision. And here in the famous illustration, it shows that the anastomosis is usually done first, and we usually do it before we even actually harvest the section of bowel, because you want to make sure that your bowel is lined up in a way so that the anastomosis comes down before you obligate yourself to a 60-centimeter section of bowel. In an open situation, of course, your continent diversion is almost always already formed, and you're bringing this anastomosis down under direct vision. And make sure that it's a great anastomosis, because you should redo the whole thing if you feel that the anastomosis isn't completely watertight. The handling of the ureters is no joke. And I have a little bit of chest pain whenever I see somebody secure a ureter with a forceps. It's taught, and maybe it's only legendary, but the more you manipulate the ureters, the more likely it is that this terrible blood supply can be compromised. So once you've isolated the ureters robotically, please don't manhandle them with the robotic needle drivers. It's okay to secure them and to make them stationary using sutures. And here you can see that we're doing a right to left, side to side anastomosis. This is of course a Wallace type anastomosis, and this will be sutured to the most proximal part of the of the bowel. But you can also see here that Bricker can be done with the side-to-side spatulated anastomosis that Bricker first espoused robotically. But if you manipulate these things more and more using the strength of robotic needle drivers, you will probably compromise that blood supply. It's always good to check the blood supply robotically with ICG and fluoresce them to make sure that the ureters are of good vascularity. It's always prudent to cut back on the ureter, especially the longer ureter, to ensure that you're getting to a part that the blood supply is adequate. So that was a brief foray into some of the complications of urinary diversion. Urinary diversions are associated with a higher readmission rate, almost always due to the bowel complications. However, your complication rate can be lowered with good ureteral and pouch drainage, very stringent patient compliance, and monitoring of electrolyte abnormalities. Ileoconduit, of course, is safe, durable, and most popular in the United States, but does come with its complications, including peristomal hernias and the problem with cosmesis and appliance fitting. But all these things can generally be predicted before surgery. And if you use a good 15-centimeter section of bowel with good vascular supply, it usually heals well. Continent diversions must store urine at low pressure, and the patient must reliably drain the continent diversion or all will go awry. Again, with ileum and colon, the most common metabolic abnormality is hyperchloremic metabolic acidosis, usually with hyperkalemia, depending on the acute or chronic nature of it. Robotic intracorporeal urinary diversions may offer some advantages over open, but must not compromise long-term results and must adhere to all those strict oncologic and surgical paradigms we use to ensure good vascular integrity. Some questions that I've seen on in-service examinations. Question number 1, which of the following may be complications of neoadjuvant chemotherapy, that's platinum-based chemotherapy, radical cystectomy, and urinary diversion? So we know on the LSATs that sometimes you can have all the choices be correct. So here, hearing loss is definitely a possible complication of neoadjuvant chemotherapy. Acidosis, almost always a complication of urinary diversion. And if your kidneys have become compromised by that neoadjuvant chemotherapy, it can also worsen the acidosis. Pyelonephritis because of ascending infection, sepsis, of course, and megaloblastic anemia can be a complication of urinary diversion if a segment of ileum that's too long has been compromised. So the answers here would be all of the above. The ileum differs from the jejunum in that it has a larger diameter. No. The mesentery is thinner. No. It has multiple arcades. Yes, the ileum has a double row of arcades. And the vessels of the mesentery are not necessarily larger, and the mesentery is not necessarily longer than jejunum, but it does have the double arcades. Again, an historic question: when stomach is used for urinary diversion, i.e. a gastrocystoplasty, the electrolyte abnormality that most commonly occurs is a metabolic alkalosis. And of course, you're losing hydrochloric acid, you're also going to lose chloride. So that's hypochloremic. So B, hypochloremic metabolic alkalosis. Systemic antibiotics and elective surgery should be given, of course, before the skin incision is made, generally 15 to 20 minutes beforehand. Stapled anastomoses are very popular robotically. Some of our general surgery colleagues like to reinforce the stapled anastomosis with a hand-sewn anastomosis for the terminal anastomosis. So what are some of the advantages? Well, stapled anastomoses compared to sutured anastomoses have fewer leaks. That's not true. In fact, if you use the terminal anastomotic staple line, it may have more leaks. It's less compatible with urine. No, that's not true. Stable anastomoses have a lower incidence of bowel obstruction. That's not true. And they may return bowel function earlier. And studies have shown that's actually not true either. In fact, some general surgeons will resect ileum or isolated sections of jejunum, and those patients can go back on a regular diet 2 days later. So there's something different about a urinary diversion that leads to these problems with ileus. So the answer here is reduced operative time. So a stable anastomosis does nothing other than reduce your operative time. The abdominal stoma for a conduit should be flush with the skin. That's not true because it's going to have a hard time for the appliance to sit on it. It should be placed through the belly of the rectus muscle. That is true. That hopefully will reduce the problems with peristomal hernia. The stoma should be made as a loop to reduce peristomal hernia. No, that is not true. A loop in and of itself doesn't reduce peristomal hernia. It can be made with the colon for the least complication rate. That's actually not true. In fact, if you use descending colon, like you would for a colostomy, it's actually very difficult to do anastomosis between the transverse colon and the sigmoid colon because of the lack of mobility there. The only time you can use descending colon for a urinary diversion is if it's already there and you're being asked to go back in for a patient who needs some sort of GI surgery and they need a cystectomy at the same time. The loop end ileostomy is best used in the obese patient. It doesn't have any advantages over the thin patient or a female patient or in spinal cord patients. The jejunum, again, we're not using that much. This is the one where you tend to lose a lot of sodium because the Km of the jejunal membrane allows for more rapid reflux of sodium into the urine. And so you tend to lose sodium into the urine a lot. And often you can get a metabolic acidosis. So this is the one that tends to be hyponatremic. In this situation, however, we're looking for acidosis, and you almost always get a hyperchloremic metabolic acidosis. If the choice here also showed hyponatremic metabolic acidosis, that would be the exact right answer. Low sodium, but metabolic acidosis. The primary advantage of transverse colon, you have to think about, okay, radiation injury. So transverse colon is the only area of the bowel that won't be injured by radiation, usually. So you have to eagle eye directly into choice C. It doesn't offer any better electrolyte abnormalities. It's no better for short ureters, and it doesn't really help you perform any non-refluxing anastomoses any better than ileum. It's just less likely to be injured by radiation in the olden days. Last question. In urinary intestinal diversion, the serum creatinine may not be an accurate reflection of renal function because of interfering substances in the urine, tubular secretion, tubular resorption, bowel resorption, or decreased renal elimination. So clearly, if you have renal failure, you may have decreased renal elimination of creatinine. And you may have changes in your tubular secretion of creatinine or resorption. But it's generally thought that some creatinine is absorbed directly by the bowel. And this may give rise to an elevated serum creatinine without any evidence of urinary obstruction. And so the answer there is D. I want to thank you again for your listening in on this talk. Again, you can email me at jlphillipsmd@gmail.org. And you can also send in your history articles at editor@ijuh.org, or you can read Dr. Herr's article on the pioneers of cystectomy at our website, www.ijuh.org. Thank you so much.